Hello, everybody. Thanks to everyone who's watching. I'm Dr. Stephanie Morley, and I'm the president of Vetlen. Our innovative new product called the Vetlen Pouch is a local drug delivery device that allows for sustained release of antibiotics directly where you need it most. In all of our conversations with veterinarians, which we've spoken to many veterinarians over the last year or so, treating biofilm infections is something that they want help with, but they have questions about how exactly does it work and why are biofilm infections so difficult to treat. So we brought on Dustin Williams, who is the inventor of the Vetlen pouch. And as someone who has dedicated his entire research career to combating this problem, who better to educate us about biofilms than Dustin? So thank you for joining us today, Dustin.
Quite my pleasure. I'm excited for this. Been looking forward to it for some time. Thank you for having me.
Absolutely. So first of all, I think everyone's going to want to hear a little bit about you and what you're about and what brought you to creating this product.
Yeah, well, so let's see, how far back do we go? No.
Pick
No,
a
I'll just
time.
kind of, yeah, I'll kind of start. It was interesting to me. So my undergraduate degree is in microbiology. And I guess I'll even take a quick step back, not share too much about this story, but I lived in Ecuador for a couple of years, serving a mission for my church. But there was a very pivotal day for me when I met this guy named Eduardo on the street. As a cobblestone street in this area called Lucha de los Pobres. And we were coming down this cobblestone street, and he was dual amputee. And his legs were so infected, and they were calloused and rough. And I asked, what's the problem? His wheelchair was sitting next to him, was busted. And he said, yeah, my wheelchair's broken. I have to drag myself around from place to place to get to where I want to go. And anyway, talking with him, seeing his infections, he was so infected, he actually had insects coming in and out of his leg wounds. And I really genuinely decided that day I'd love to help people walk, and I'd love to help solve infection problems. So as part of the first part of my kind of career was helping develop new prosthetics and bionics for soldiers. And while doing that, we developed a technology. I was part of the team that developed osseointegrated implants. So, it was fun for me, very life fulfilling to have a check mark to help people walk again. So we have these prosthetic, technology in hundreds of soldiers across the world now and civilian patients. And so, in doing that, I also wanted to get a degree in microbiology to help learn how to tackle infections. So in developing those implants, I learned about biofilms and at the skin implant interface. So while I was doing my undergraduate degree, the funny thing is I only heard biofilm, I think, one time in my entire educational experience. So, but doing that actual research, I really identified the problem and said, how do we tackle this? And so I, for a long time, worked in active release coatings, which I'll talk more about here in just a little bit. But as I went from microbiology and then helping develop these implants, I went into getting a PhD in biomedical engineering, where I kind of fused these worlds of microbiology and biomedical engineering to develop medical devices and antimicrobial technologies. So that's a little bit of my journey into science and stemming from some life experiences.
So how did you come up with this idea for the Vetlen pouch?
Yeah, a great question. So stemming from that, one of the ideas that we had, way back in the 70s, some scientists were using silicone polymers to load antimicrobials into, and that field's been around for a long time, developing what are called either passive coatings or active release antimicrobial coatings. So for a long time, for a little bit more than a decade, I worked on developing multiple antimicrobial coatings for orthopedic implants. And after a decade and after kind of running into a lot of FDA challenges, if you will, how do you actually get these things across the finish line and into clinical use? And also recognizing some of their important limitations is really the genesis of the Vetlen pouch, and I'll give a little bit more detail about that. So I had developed some active release coatings that have had promise, and they might have their place. They are going to work in some instances, some cases. But I sat back one day and I said, listen, there's a lot of limitations with active release antimicrobial coatings. For example, whatever antibiotic I put into this or antimicrobial I put into this coating, I am locked into that antimicrobial. And also, however much I put into that coating, I am locked into the amount. I might only be able to put a few milligrams, and in some cases, a lot of coatings only have micrograms of antibiotic in their system or in their polymer network. And that's a severe limitation if you're talking about biofilms. We're going to talk more about, what it takes to actually, knock down a biofilm and actually kill it. And so, sat back and I said, these things, we have to address these things, these issues, these limitations. And also, we have a product that's left behind. Anytime you put a polymer on a metal implant, if it's meant to be in there for the lifetime of the patient, that polymer is going to be in there for the lifetime of the patient and have some inflammatory response or something going on long term. And so I sat back one day, and an unfortunate, circumstance, my uncle had passed away on the dialysis table. And I was thinking about him. And I was thinking about these limitations of my active release antimicrobial coatings. And all of a sudden I had this fun experience where just ideas started flowing into my mind of, oh, hey, think about the material that was being used originally for dialysis. That's like a cellulose material. And then I thought I could, and that's a semi-permeable membrane meant to keep things out, right? Or maybe even keep some certain things in. But I thought I could use that material in exactly the opposite way it's meant to be used in most cases, and control the rate of release of antibiotic out of a pouch made of semi-permeable material. And if I connected a tube to it, a catheter, then I could refill it, which is a necessary thing to be able to kill biofilms, which we'll talk a little bit more about here also in just a minute. But all of these ideas started generating into this idea of developing a refillable pouch that could sustain local high-dose antibiotic therapy. And it got around a lot of the limitations. It's removable, doesn't stay in long term, so it's not going to have this chronic long-term inflammatory effect. The other thing is you can switch out the antibiotic if you need to. You're not locked into whatever antibiotic you put into a coating, for example. And so that was, a real benefit of the Vetlen pouch. In addition, I could put it in essence anywhere I need to in the body. I'm not locked in to a certain implant that has this coating on it, and then I have to redesign that coating for some other implant or whatnot. It's so versatile, it can be placed essentially anywhere. So it was a fun idea. And I took $37,000 of activity money at my university and to flesh out this idea to see, does it have any teeth to it? And had a remarkable postdoc at the time, Nick Ashton, come on and help develop this technology, who you're going to also be talking with. And we took these $37,000, we made a prototype of the device and tested it in some sheep initially, and it worked phenomenally well. And that $37,000 turned into $14 million in DoD funding, a manufactured product, and 5.8 million in private capital for the company developing this. And it's been a wonderful journey ever since.
And many animals already helped by it too.
Yeah. And so, that's another topic I hope we're jumping into, because that's the fun part.
Yeah.
I mean, the whole thing for me is, how do I heal people, right? I'm not really driven by anything else other than I want to help advance technology. I want to help make a real clinical difference. I love doing that both in the animal and the human space.
So let's talk a little bit about what biofilms are and why they matter.
Yeah, really good question. So biofilms, we're talking about the juggernauts of bacteria here. So if I go outside and I grab a handful of dirt, there's going to be about 10 billion bacteria per gram of dirt, if it's nice, moist dirt that's outside. All kinds of dirt have different loads of bacteria. But the way that bacteria like to live out in that dirt, out in the natural world, if you will, natural ecosystems, is in this biofilm phenotype. And it's really a survival mechanism for bacteria. When we grow bacteria in the lab, a lot of times, we're putting them in culture tubes. They're planktonic bacteria. They're free floating in a solution. And because they're free floating, they're highly metabolically active. Antibiotics typically work much better against highly metabolically active bacteria. And so when you're in the lab and you're doing in vitro assays, in vitro tests, you're in this, nice clean test tube. It's pretty easy to kill bacteria in that environment. But then once you get into this natural world where bacteria are in this biofilm phenotype, which I'll describe here in just a second, a little bit more, they're much harder to kill. And that's because they're in this survival state, right? They're not in the luxury hotel of a test tube. They're out in this natural world that's very difficult to live in and to survive in. And they have these survival mechanisms. So in this biofilm, one thing that they do just straight up is they just want to cluster together. Bacteria want to stick together. So back in the 1940s, this is where one of the initial observations was actually by Claude Zobel, guy from Idaho who moved down to San Diego at the Scripps Institute of Oceanography. he took some glass vessels and he stuck them into seawater. And he wanted to just count bacteria in seawater. And he started observing that the bacteria, he couldn't find them in essence in the seawater. They were stuck to the glass vessels that he put down into the water. And he said, well, that's curious. And he counted the bacteria. And he says, oh, that's interesting because within a matter of time, the number of bacteria I collected in the water are actually the same number of bacteria that are stuck to the glass. So he made the conclusion that bacteria preferentially adhere to solid surfaces. This theory was formalized through civil engineers and wastewater systems when they called these clusters of bacteria, they called them biofilms, even in the 1960s. And then in 1978, Bill Costerton kind of came along. We call him maybe the grandfather of biofilm discovery and research. And he said he kind of collated and corroborated all of these findings and these observations into this biofilm theory that formalized about in the 80s. And that's when orthopedic surgeons also really started seeing the problem because orthopedic implants were also beginning to come into play in the 70s and 80s. And they started having these infections. And so they started saying, hey, we've got, these difficult to treat infections, which I'll talk a little bit more about here in just a bit as well. But and some of the early observations in the 80s and how I detect a biofilm infection. But back to kind of the biofilm phenotype. In about 1991, a cool technology came out, the confocal laser microscope. And for the first time, they were able to actually capture three-dimensional images of these biofilm clusters, these biofilm networks, and these biofilms. And they found that they have water channels that kind of run all throughout them. And so we gathered all of this information, started doing a lot of research on biofilms and learning their characteristics. And we found that they have diffusion gradients of oxygen and nutrients throughout this community of bacteria that sticks to a solid surface or an avascular surface, for example. And that in part contributes to their tenacity, if you will, their ability to deflect antibiotics. We found, and our scientists found, that they can actually see antibiotics flowing through these water channels, just passing right by the bacteria they're meant to kill. So they're not actually getting into the cell and killing the bacteria, they're just flowing through the system. The other thing that they found was this oxygen gradient that develops in a biofilm. So there's way more oxygen on the outside that's being gobbled up by cells that are metabolically active on the exterior regions of a biofilm. But down in the core of the biofilm, there's much lower oxygen profiles. And that leads to a lower metabolic state and a lower turnover state of bacteria in the deep regions of a biofilm. And you start turning that into like, let's give a visual, for example. If I'm riding a bike at high speed down a hill and I throw an umbrella into the spokes, that person's going to go flying off the bike. But if the bike is sitting on the sidewalk and it's not moving and has no action or kinetic energy, if you will, I put the umbrella through the spokes, nothing's going to happen. We equate that kind of to a biofilm. You have these different profiles of bacteria. If I have these highly metabolically active ones dividing on the outside and I throw antibiotics at them, that's what antibiotics are meant to kill a little bit more rapidly. Then they're going to have a decent effect. But the ones that are deeper down in the core, they're going to be less affected because they're not turning over their cell walls. They're not turning over as rapidly. Their inner cogs are still going because they have to stay alive, but they're just kind of quiescent in a dormant state. So these are some of the characteristics of a biofilm that make them super tough to kill. They also just like to stick to things, right? So they create this extracellular polysaccharide substance. It has a lot of different parts and components to it, but it's like a scaffold that bacteria stick to and encase themselves in. And that makes it very difficult for phagocytes to come in and phagocytose them. So they have these anti-phagocytic effects. So they have all these armaments, right, to protect them against antibiotics, against your phagocytes, and they like to stick to things, especially avascular surfaces. So you have a wound that has necrotic tissue, you have bone that has sequestra, you have a metal implant that's avascular. Biofilms are going to thrive in those environments, and they're going to thwart most of everything you throw at them. So that's really the problem with biofilm, is they're amazing features, they're amazing aggregates of bacteria, and they're super tough to kill. So that's what we've been working on for a couple of decades now.
So how does a veterinarian know if they're dealing with a biofilm-related infection?
Yeah, that's a great question. So there's a few, this is kind of going to go back to the 1980s, what we learned about biofilm-related infections. And, some of their features, some of their hallmarks, if you will. So if I remember the year correctly, we're like 1982, 1984, a couple of big studies came out One of the original ones was with a patient who had a pacemaker. And I'm using a lot of human data here because that has been my focus for so long, but it directly correlates to the veterinary space. So these outcomes are going to be similar. These infection outcomes are going to be similar. So let's go back, to that Gristina et al. Paper that Bill Costerton was part of as well. And what they found was a patient who had a pacemaker put in, and he was in essence out gardening and got a scratch in his elbow region. And a couple of days later, the scratch didn't really have any issues, but the pacemaker, his chest started hurting. So he went to the hospital, got a round of antibiotics. He was cleared up, went home. A few days later, he goes back to the hospital. Oh, my chest is hurting. Something's wrong. And he had a fever and he's infected. Give him another round of antibiotics. He's getting better. He goes back home. And once again, a few days later, oh, chest starts hurting. It's this cyclical effect of infection that goes on. It's an indicator of biofilm related infection. Because what happens is like we kind of go back to this biofilm. A lot of times when you give a short course of antibiotics, you're going to kill those planktonic or the bacterial cells that are in a little bit higher metabolic state. You're going to kill them sufficiently. If they're in the vasculature flowing, they're going to be killed, and they're the ones that cause these raging high, really high grade infections, if you will. So you give a course of antibiotics, a short course of antibiotics, for example, and you're gonna push that back. You're gonna push the infection down a bit, but the biofilm hasn't been fully killed, and it serves as a reservoir of infection. So one of the hallmarks you'll see, and this was another paper was like 1984 where they saw this with a total femoral stem in a patient, and if I remember the paper correctly, we were reaching back to like 15 years ago when I read this paper. I believe he had this recurring infection for 7 years before they pulled his implant, and then he healed up. With the patient who had the pacemaker, it wasn't until they removed the pacemaker lead and they actually imaged the biofilm on it and they put a new system in, he didn't heal up until they did that. So a big deal with biofilm is, mechanically removing it is one of the best things you can do. But you're going to have, if you don't remove that problem or kill it sufficiently, you have this problem of recurring infection. The other interesting thing we've found in a lot of our animal work over the past roughly 20 years with biofilm-related infections is they're not necessarily raging, really severe infections. A lot of times, and this isn't like a singular circumstance. This is kind of a generality. But a lot of times it's just very difficult to treat infections because you might not even realize they're there at first, right? So there just may be some irritation and some pain, but biofilm bacteria or bacteria dwelling biofilms, they can dwell in this low metabolic state, quiescent state. And so they're not necessarily raging, rapidly dividing, causing these, high infection, raging infections, super high fever, circumstances. And so one of the indicators might be that, you just have kind of chronic issues in that space that don't seem to be resolving. Of course, there's a myriad of things that can be going on, but that's kind of a couple of good indicators that you're dealing with a biofilm-related infection, recurring infection, and it's maybe a low-level quiescent state of infection. It's like, is there an infection? I'm not sure.
And there are no diagnostics out there to determine if there's a biofilm infection, correct?
None that really hit the nail on the head. There's a few things out there. I believe there's an alpha defensin for the human use case, but that's just bacteria. That's just infection. It's just kind of like counting an increased blood cell count. You just have diagnostics that indicate peripherally that there's an infection, but there's nothing that specifically tells you this is a biofilm related infection. There's a strong assumption you can make. If you have hardware in place or any foreign body and you have a difficult to treat infection, there's a super good chance it is a biofilm related infection.
Okay. So with biofilms and the bacteria associated with them being so difficult to kill in that state, what is the impact on treatment when you're trying to treat a biofilm infection, and why are our current methods sometimes not effective?
Yeah, so let me touch on the impact one first, because the fun thing for me, I mean, the meaningful kind of like, life achievement thing here is the outcome. It's having seen the benefit in the animals that have been treated. I loved seeing the story of the farm horse that, had this fistulous withers, this saddle sore that got infected. And, the great story behind that and how it was treated, I think, if I remember correctly, for up to about 28 days. And then you see this just gnarly infection and it had persisted for how many months. And then you get the picture that's you sent us that I loved, and the note, oh, the horse totally healed. We're able to put a saddle on. It's back at work at the farm. I mean, that's the impact, right? That's what it's all about. And I just to touch also, this is on our website, I know, but this is what is the meaning part, right? I loved when we had that training horse that bucked the jockey, tried to jump a barrier, and split open the fetlock ankle joint, and they put in that Vetlen pouch, a couple of weeks of therapy, and then when we get the video of the horse back on the track, I mean that. How do you put into words, right? That your technology works. It's healing up. That's
Yeah, and
super fun.
I should say to everybody who's watching this, hopefully you're watching this because you've already used our pouch or you're thinking about it, but we do have a vouch for the pouch program, and the reason we do that is somewhat selfish because we want the case studies to be able to show other veterinarians how vets are using the product because it's the best way for veterinarians to learn about new products. But the selfish part of it is we love hearing these stories. It is really motivating. So every time you send me those case studies, I am sharing them with the whole Vetlen team back at the University of Utah, and they're, spreading the word and love to see that. So I know how excited I can genuinely see. I've been on the receiving end of your excitement when I send you those case studies. So
Yeah, no, that's what it's all about, really.
yeah.
So and we really, that begins to show that we really have tapped into a major solution, a huge advancement that really honestly has not existed before. And so I just, can't stress enough how much I'd love to see more of those case studies.
So I guess let's talk about that then. I mean, the work that Pergo Scientific, which is the human-focused company, the work they did in sheep, hence our little sheep logo. We call him Lenny. He's our chief grazing officer. The
Love
work you
that.
did in sheep was on a fracture model with a MRSA infected plate. So it was very orthopedic focused, and that's the human focus. We've found in the case studies on the veterinary side that actually the majority of the cases veterinarians are using it for are soft tissue infections and chronic wounds, particularly, or traumatic wounds. So can we talk about some of the use cases where the the Vetlen pouch, I should say, would be, it's the same thing, but
Yeah.
the Vetlen pouch could be used where, it may or may not be biofilm related, but having high dose local antibiotics is the right course of treatment.
Yeah, so yeah, let me dive a little bit into that. So in the data we've collected, the pouch shines in the soft tissue space and goes and access to the tissues. Because you have vascular flow, you're going to have, the drug get to those areas a little bit better. You also have some of the anytime you have avascular system, right? The biofilms are going to be on there. They're going to dwell on there. They're going to be tougher. So you're going to have a little bit more challenging time killing the bacteria that are on those avascular or hard surface. Even in the bone, treating bone infection, once these sequestra form, where you get these pieces of bone that break off, they're avascular, and they become a buffet for bacteria just to eat and to dwell on and form the biofilms and thrive on. So that could be one of the reasons, right? You see this a little bit higher performance even in soft tissue spaces than in the other, implant or bone spaces. You might need a little bit extra therapy in that area. But the cool part about that is kind of going back to my thought process originally, is I didn't want to lock in, some cool technology into an implant that can only be used in one space. You can put the Vetlen pouch in essence anywhere. And I think it's fascinating. You go on our webpage, you look at those case studies, how many locations, anatomical locations, has been used. We've now had it in a cranial space, I understand. We've had it in a perianal space. We've had it next to a spleen. We've had it in joint space or close to a joint space, hind legs. I mean, that's fascinating. highlights its versatility. And now we have the two sizes, right? So you can have a little bit bigger coverage if you need it, or for a little bit smaller animal, we now have that 5 ml pouch. You can put it in more spaces, smaller animals.
That's
So
true.
yeah, no, that's something that's neat to me. Love the versatility, and it's exciting to see that it's working in all those different spaces, because that really was right the idea. I had the idea, and it's wonderful to see it now becoming executed.
So you've heard me say this before that I call veterinarians the MacGyvers of medicine because we have to work with whatever tools are provided to us. And so we're really excited that Vetlen Pouch is a great new tool for their toolkit. But there are other solutions that veterinarians have relied on for local antibiotic therapy, calcium sulfate beads impregnated with antibiotics, soaker catheters, powders, et cetera. So how does the Vetlen pouch, how is it more effective than some of these other alternative therapies?
Yeah, and I think a really good way to understand this is from Rocky Balboa. So one of my favorite movies and series of movies. And despite what other people might say, ask Nick Ashton, the fourth Rocky's the best with Russian fighter, and where he's working out in the barn. But he says in the moment he's like he keeps punching him, just keeps punching him, keeps punching, right? And Rocky is just letting the guy wear down. And and finally he wears him down enough to where he can take him out, right? So that's when you're talking about biofilms, you're talking about these different spaces, these different technologies. There really are different kind of weight classes, if you will, of boxing. So you're going to have a very common approach in surgery is to use a lavage, to use an irrigation, right, to get something out of there. And they're going to do the in vitro data on all of those technologies is amazing. And like I say, it's it's a little bit easier to kill things in vitro than it is in vivo because you have such a complex environment in vivo that you're dealing with. And so you are going to have some effect, but I might suggest it's going to be a lightweight effect because you're going to be able to debride and clear out, lavage these things okay, at one time with an irrigant or a lavage, and they'll do a little good. We're not, I wouldn't suggest they're useless, but you might have limited effect. And then you get into an antibiotic powder. You look at the clearance rates of an antibiotic powder being sprinkled directly into a wound site, and you only have about 12 hours of effective duration, maybe 24 in some instances. But the antibiotic direct powder is cleared out by lymphatic clearance or vasculature quite quickly. And when you're talking biofilms, I actually just finished a data set we're about to publish in the lab where we show we need to wallop biofilms for a minimum of 10 days to even begin to see a pretty solid antibiofilm effect. So 12 to 24 hours, you're going to reduce some bacteria, you're going to protect against a little bit of infection, and in some cases it'll work well, depending on what the bioburden level is. But it's going to still be kind of in that lightweight class. And then you go to any kind of bead that you're going to develop with an antibiotic loaded into it. We're still kind of maybe in that middleweight class, right? You're going to get maybe 3 days of coverage. Some data is going to show that you might have 30 days of delivery, but it's going to be in single microgram per mil ranges that really aren't going to have a significant effect against biofilms. Because one of the things about biofilms is if I take a minimum inhibitory concentration and MIC profile, that relates to planktonic bacteria, but it has really nothing to do with biofilms. So to kill a biofilm, I need to have supra MIC concentrations, much higher concentrations than what I can achieve just by tapering quickly and just hovering above an MIC level. So again, with any kind of bead product, you're going to get some limited effect. You might be in that middleweight class. But really, I call the Vetlen pouch in my own mind, I call it the biofilm buster. Like I love Iron Man. He built the Hulk Buster suit. And it really is the biofilm buster. I mean, it is the heavyweight class. We're now talking where we can deliver milligrams, hundreds of milligrams of antibiotic, if not even grams per day for up to 30 days. And that's what you need to really kill biofilm effectively. You've got to wear it down to where you can finally take it out, just like Rocky did, right? Let people hit him till he can finally take him out. He can wear him down, but then he'll take over. And that's really what the pouch accomplishes.
Do we need to think to rename this or something? Or do we need a Rocky theme? I had no idea that was such
I'll
an
call Sylvester
inspiration.
Stallone. We'll see if he's available.
Awesome. Well, in all this conversation, is there anything about the Vetlen pouch, about you, about your lab, anything that we didn't touch on that you think would help veterinarians really understand the power of the Vetlen pouch and how to use it?
Well, I'll highlight just a couple of things there again, because I think the way that it goes in, comes out, we thought a lot through this. We wanted to make it relatively as simple as possible for a surgeon to be familiar with it. It goes in and comes out very much like a surgical drain. That's on purpose. It's super simple. No pumps or batteries required. All of the release profiles, all of it is based on concentration gradient driven process, fixed laws of diffusion, passive diffusion. I think you'll talk about that more in another call. But that's one thing I wanted too. I wanted this to be pretty simple and to not be complicated, to not have to have something that you have to check, a monitor on every day, or have electronics or batteries involved. And that's actually a really, really big thing for the military, right? We are developing this for human use, and the military, if you're going to put something in a pack, in a kit, on a truck, lightweight, right? Lightweight is what they want. And this is probably the lightest and most effective anti-biofilm product you will be able to find with the most efficacious outcome. And so I love that. I love that it has a simplistic nature to it, and love that it's highly effective. So simply yet effective. And yeah, just invite people to please keep using it, because I mean, that it's just like the fulfillment, seeing the animals healed and seeing the outcomes and seeing that it works out of our hands, out of, all of the controlled science we do in the lab. It means the world to me. So thank you.
Well, thank you. Thank you for inventing this. Thank you for bringing this to market. Because as a veterinarian, first time I saw it, I thought the same thing, and I've been super proud to be part of this team and helping get into the hands of veterinarians. So thank you for that. And thank you for your time. We really appreciate it.
Thank you for having me and for driving this forward. Without you, we would not be where we are. So
Well,
very
thank you,
excited.
Dustin. All right. Have a good day.
You too. Thanks.